Good afternoon, good night, well, good evening, depending on the time. It is an honor for me to be part of this myelodysplastic syndromes group symposium from GLAM. So we will now move on with the second session, Low Risk MDS. I will share the stage as chairman with Dr. Salinas and Dr. Carlos Huaylinos. It is an honor for me to introduce the panel, which is made by Dr. Pierre Fenaux, Dr. Magalhaes, Dr. Gabriela Vidal, and Dr. Carlos Hernández. Let's now start with Dr. Fenaux. He's a hematology professor and director of one of the sections of San Luis Hospital in Paris. He's involved in translational research on myelodysplasia and AML. He's a founder member and chairman of the French group of myelodysplastic syndromes. Dr. Pierre Fenaux, we would like to welcome you and give you the floor. Thank you very much. And well, first of all, I would like to thank GLAM and their invitation to this symposium. Let's now speak about new strategies in treating low-risk MDS. As you know, these are IPSS low or intermediate. Part of this intermediate are having a score below 3.5. And from those patients, I think that the purpose of treatment is that of improving the cytopenias, anemias, and the quality of life. So anemia is the predominant cytopenia, but there's a ratio, a proportion of patients who have like thrombopenia predominantly. So in low-risk MDS, it's very rare to see an isolated or predominant neutropenia. Well, there are two ways of treating anemia. One of this is to try to correct that line which has a problem, which is the curve in green. And the other is by way of blood transfusions, regular transfusions. So they will spend half their time below 8 grams of hemoglobin. This curve is maybe the most important of the presentation. There is a tight relationship between the quality of life and the hemoglobin levels, and there's a sigmoid curve. A patient who's over 10 grams has a improved quality of life if he's compared to someone who's below 8. Now we will see first what's the current status of treatment and how to improve treatment. To the current treatment, first-line treatment, we try to use drugs to improve the anemia and to try to avoid transfusions, and most of the patients receive EPO or darbepoetin, mainly without 5q deletion, and with those with deletion, EPO is less efficient and lenalidomide is most efficacious. For second-line treatments, this includes anti-lymphocytic glutamine, lenalidomide in non-DEL-Q patients. First of all, we know that EPO has a more or less 50% response rate with a median duration from 20 to 24 months. Lenalidomide with deletion Q, 5Q, gets 5% transfusion independence and 50% complete cytogenetic response and a mean duration of a little more than 2.2 years. Depending on the line, the immunosuppressive drugs, anti-lymphocytic globulin allows to get up to 40% response rate. But this is actually in a selected population of patients younger with more than one cytopenia and hypocellularity specifically. So this is used in a minority. Lenalidomide without 5q deletion gets them to have 25 to 30% transfusion independence and a median duration which is less than 1 year. The hypomethylating agents, I think that in those who have a truly low risk where anemia is predominant, the rate of response is pretty low. It's 20 to up to 30%, but it is very low and kind of disappointing for these patients. We know that EPO improves survival if this is comparing patients treated with transfusions. It's an important treatment not only to correct anemia, but to improve the survival of those patients. And we also know that anti-lymphocytic globulin, if compares this blue curve to the curve below, might also improve the yellow curve, and thus the survival will be much better. On the other hand, using lenalidomide or hypomethylating agent second line does not seem to improve survival if it's compared with transfusions on second line, as you can see here, with a median of almost 4 in this study. So how can we improve the prognosis? We can see, first of all, to optimize the use of drugs available, new drugs, and what's the role of the halo transplant in patients who have a low risk. The drugs available. Well, first of all, what we discussed in our group is that those patients who started EPO fast enough, meaning in the first 6 months within the diagnosis time, they had a transfusion-free time, this blue curve, which is better than those patients who started treatment with EPO later on. So what this work showed is that patients who had 2 mutations or less had a better erythroid response. Maybe one possibility is to start treatment fast enough in patients who have less mutations, and this could somehow be useful to avoid delaying the transfusional dependency. So far, we have a clinical trial that compares a early and late start of EPO, more or less 10 grams or 8 grams. And this has been randomized, so we have to see if this has some interference in mutations, the number of pathological clones. Another drug is lenalidomide. It's been proven that the red one is placebo, the yellow is len 5 milligrams per day, and the blue one is len 10 milligrams per day. So it's 10 milligram 3 weeks per month. As you can see, there's an effect on the of the doses on the transfusional dependence, and even more importantly, the dosing is very important. It's related to the percentage of cytogenetic response, not only erythroid, but also cytogenetic. What we were able to show, this is a joint analysis from the trials published. Those patients who obtained a cytogenetic response, they had a less important evolution towards AML and a better prognosis. So this might suggest that it is important to keep the dosing in those patients. You can do this with GSSF to keep the neutrophils, but also there's possibility of using thrombopoietin agonists, as you can see here, which might reduce this risk and the importance of thrombopenia with the treatment. Another question regarding lenalidomide. When to start treatment? In most of the patients, this drug is approved in patients who have a 5q deletion who depend on transfusions. What Maria Scampello did for this Spanish group, and we've also taken part of this, the GSMD, it randomized patients with 5q deletion from starting treatment right away with a hemoglobin below 12 grams compared to those patients who were randomized between started the treatment or getting placebo. What this showed, when you start treatment right away, you then delay the transfusional dependency in those patients, and this is quite significant. And apart from this, the response rate is more important in those patients because we have a 70% rate and a cytogenetic rate, which is also interesting, of 50%. Something that we still don't know is starting right away treatment can delay not only the dependency on transfusions, but also the evolution, including the emergence of mutation. And we will take a look at it later on with a more in-depth follow-up and maybe with more patients. What we have also showed some years back is that in patients who were resistant to EPO, adding lenalidomide in those patients could restore the response. And we have compared this without 5q deletion, lenalidomide plus, against lenalidomide plus EPO. And there's 52% compared to 30%, which is the erythroid response. It's actually a second-line treatment that looks very promising for these patients. And recently, the North American group has confirmed this. They have randomized groups with the response rates that are different. There's a greater response here of 40% against almost 12%. So I think this is a very interesting treatment. As I mentioned a while ago, in our experience, azacitidine in our patients who are resistant to EPO only managed a transfusional dependency rate, which is actually not that high, and there's no much benefit if you add EPO, which is the contrary that has been seen with lenalidomide. The Americans, our colleagues of the North American group, have shown that a briefer course of hypomethylating agents could get to a very interesting response rate, up to 70% in this group of patients, with very few side effects. Well, once again, this is not only patients who are anemic against what we've seen before. It's not the same patients, but it might be interesting because there are responses on platelets and lineal responses as well. A very important and specific category is MSD it's MDS with autoimmune disease, which is very frequent, by the way. And we've treated 22 patients who were suffering a very severe autoimmune disorder, and many of them had a response with AZA, but not only associated with MDS, but also CMML. We have reached to certain conclusions in a retrospective study and a prospective study with azacitidine with these patients, and we don't have the last pool of results that I hope will be soon ready for ASH. I know that Silvia will speak about this trial, but this is just a trial that compared chelation with the ferrasurox or placebo. It's been discussed and it looks very interesting. And in some cases, the ferrasurox in 15% of patients can include cytopenias, but this is something that still needs to be defined. And we know that in patients who will be transplanted, it is very important to keep to avoid iron overload before the transplant. What about new drugs? There are many new drugs in the horizon. I won't speak about Pevonitstat, which is very interesting in a certain percentage of patients. It's been presented at ASH last year. I won't speak about APR 246. I will do this tomorrow in the presentation scheduled for tomorrow. I will speak about imetelstat and luspatercept. There are others similar. There are inhibitors, and it might look very preliminary in using this with patients because so far we are not sure of the results. This is a telomerase inhibitor. This is the first inhibitor that we use, and in a study with patients who have failed EPO, who did not receive hypomethylating agents, there's an independence rate which looks very interesting, 42%. It's a pretty small experience, and there's a phase 3 that randomizes this against placebo. IDH1 and 2 inhibitors in MDS, we know that in high-risk patients, there's a 50% of response. And also in low-risk patients, the responses will be discussed tomorrow. And what about the TGF beta inhibition? We know that this inhibits the erythropoiesis, and there are components like GDF11 and others which inhibit erythropoiesis. And luspatercept is a drug which is made by an FC and a receptor of activin that can capture ligands as CDF11. Interesting enough, it inhibits the signaling of TGF and acts late in erythropoiesis against EPO, which acts early on. And this is important to conceive different associations with these drugs. It's been used with patients with ring sideroblasts in an essay comparing luspatercept with placebo. A randomized in 2 versus 1, 2 to 1 ratio, and there's 40% of transfusion independence with luspatercept. We were surprised by a response rate of 15% in the placebo arm, which shows the importance of adding placebo branches because they are more transfused before entering the trial. So these responses might be false, but this is something that is worth keeping. And the response rate depends on the transfusional requirement. When it is too high, more than 6 units every 2 months, it's 21% in patients who are less transfused. And the DOR, duration of response, with a median of 80 weeks. And you see here that the placebo, well, there are some patients who have durable response, which is, of course, a false response. If we added the transfusional independence to this response, is 2/3 of patients, more or less, who are indeed responding to luspatercept, and there's so few side effects which then decrease in the long term, and there's so little progression. All of these progressions that we saw in this trial happened with patients who had additional mutations, additional to CF3B1, Bronx1, and so on and so forth. But there was no increase in the luspatercept arm. The perspectives with luspatercept, as I mentioned before, an association with EPO, lenalidomide, and the use in MDS with ring sideroblasts. And we will start a new trial with these patients who are resistant to EPO. Well, they will be randomized to luspatercept or luspatercept plus EPO, and we will work with an Italian group for this trial. As I mentioned before, there's a minority of patients with predominant thrombopenia, and we know that the thrombopoietin agonists give an answer in half of patients with romiplastic. And this is something that proved that if romiplastic compared to placebo did not increase the progression to AML, and it didn't modify survival, and L-Trombopag with a response rate of 47% is very similar to that of romiplastic. Well, these are just a few patients, but it seems that the risk is not increased. Well, there's a role that the allotransplant will play here. There are patients who are resistant to EPO. These are generalized elder patients, and most of them are not candidates to transplantation. When we analyze transplant curves, there's always an initial failure, meaning that 20% more or less have a death related to transplant. The problem with allotransplants is that there are a series of patients which have been transplanted like 10 years ago were published. So we have improved the prognosis, but of course, these are patients who die earlier. It was something which represents a problem. We know that allotransplant might be giving us better outcomes than other groups of patients. And this is a recent curve showing that the haplo in blue has almost equivalent outcomes to those patients who have a perfect or matched donor. But I think that all of these groups are performing haploidentical transplantations. This is not totally or equal in terms of comparison. What could we say about this? I think that there are patients with ring sideroblasts who only have an SF3B1 mutation, and those patients will never progress to ML. And if they do it, they will have new mutations. So they will have to be followed up very closely. And they are not candidates to transplantation, but these patients are normally over 60 years of age. They still have a risk. And those patients who have or showing progression, or those who have TP53 mutation with a BAF of more than 20%, or with 5q deletion who are not responding, they will be then candidates. The other patients here, I think that we have to pay attention to the comorbidities, the age, the quality of the donor, which is more or less similar to everyone, the response to previous treatment, the severity of cytopenias, and maybe mutations, and of course, the patient's choice. This is not an easy decision, and we have carried out a study with intermediate risk patients, and those patients who had a donor that were transplanted and those who didn't, they weren't, except in those cases where there was progression. And in transplanted patients, what we saw is a transplant-related death of 15%. Most of these patients are over 60 years of age, even up to 70 years. And in these patients, well, there's a proportion of patients who die from the transplantation, and very fast indeed. So it is very hard to choose when or if they need to be transplanted. And finally, I would like to thank the Department of Hematology and Immunology in Paris and our GFM, which is a group that activates clinical trials, especially with other European countries. And as always, we are here for collaborating with you in any sense. Thank you very much. Thank you very much, Dr. Fenaux. Excellent presentation. And now we will move on with Dr. Silvia Magalhaes' presentation. She's from Brazil. Silvia, the floor is yours.
Hello, everyone. That I'm very grateful and even proud to be here in this Latin American Myelodysplastic Syndrome Symposium. I was here at the first one, at the very first one, as well as in the very first one, Latin American Symposium from the MDS Foundation. So I'm very proud to be here, and I thank the organizers too for this opportunity. I'm going to talk about iron overload in MDS. Iron is essential, as all you know, for a variety of essential biological processes. Excess of iron can be toxic and causing cellular damage and secondary organ dysfunction. So it's very important for us to check and monitor iron status. What we can do by serum ferritin, transferring saturation, and T2 stars, magnet resonance imaging. Under physiological conditions, iron metabolism is strictly regulated by hepcidin. Most of the iron that circulates comes from old red blood cells, and the iron circulates bound to transferrin. As you can see in this slide, not only the transfusion therapy. These erythropoiesis or ineffective erythropoiesis can induce the release of erythropoietin and the proteins, cytokines like GDF-15 that decrease abscissing. There are some important proteins that play a whole important role here in iron metabolism. Besides abscissing, we have ferroportin, and of course the transferrin as well. In lower risk MDS, anemia is the hallmark at presentation, and most patients will present red blood cell transfusions anytime during the course of the disease. So, as we just talked about, it comes from not only transfusion dependence, but also from ineffective erythropoiesis. Older patients, our patients are older, and aging-related comorbidity potentially increase toxic effect in these patients. We all know that iron overload is associated with increased morbidity and mortality in lower risk MDS. The mechanism of toxicity it's mainly due to production of reactive oxygen species. Reactive oxygen species induces lipid peroxidation, and as you can see, organ damage, DNA damage, activation of caspases, and activation of NF-kappa B, and with secondary genomic instability. So the result is damage not only to solid organs, but also to immune system and bone marrow. The clinical consequences of iron overload has been recently reviewed in this beautiful paper by Weber, recently published. And the clinical consequences are a variant of damage, organ damage. The main organ that stores iron is liver. So 70 to 80% of patients have hepatic iron overload. However, it's the cardiovascular events that are the main cause of death. Myocardial iron overload is present in 17 to 27% of patients. As we know about clonal hematopoiesis and its link to atherogenic, recently we know that there is a pro-atherogenic action of NTBI as well. Besides, we have predisposition to infections and impact not only on erythropoiesis, but impact on bone marrow microenvironment and, of course, on overall survival, although not conclusive. Here we have a meta-analysis of the impact of serum ferritin on overall survival. 6 articles were included in this meta-analysis, and a significant association between overall survival and serum ferritin was observed, especially serum ferritin more than 1,000. The risk was also elevated, significantly elevated, when a serum ferritin more than 500 was considered. So the conclusion of this meta-analysis are there is a worse survival in patients who had higher ferritin. There is a negative impact on overall survival, and this impact is already seen in patients with serum ferritin above 500. And of course, prospective studies are necessary, are needed for us to better understand this relationship, and especially to clarify if there is really a benefit of early regulation therapy. So in summary, these studies suggest that patients with iron overload have reduced survival. So next question is, does iron chelation significantly improve outcomes of lower risk MDS patients? This is the great question. So what would be the benefits of iron chelation in our low risk MDS patients? So prevent toxicity, reduce secondary organ dysfunction, reduce infections, and of course there is a possibility of reduce of have anti-leukemic effect. We have now 3 iron chelators, but in MDS, the Ferazerox has been most frequently or used. Of course, there are many new therapies that aim at iron metabolism, but all these therapies are in the very, very early stages of development. There are many meta-analyses about reviewing the effect of iron chelation on overall survival. So that one is published in 2019 and include 9 non-randomized trials, prospective and retrospective. So significant reduction in risk of mortality was shown in patients with iron overload treated with iron chelation therapy. There was no association with decreasing risk of progression in this study. And the authors pay attention and say that there was a significant heterogeneity across the studies. As you can see in this spot, the black spots, there are patients, median overall survival of patients chelated compared to patients non-chelated that have inferior overall survival. And when we see the overall survival here in this forest plot, you can see that sides are in favor of iron chelation therapy. This is another meta-analysis published more recently in 2020. And this meta-analysis included 13 prospective and retrospective studies. And the results indicated once again that iron chelation therapy were associated with prolonged survival, overall survival, and leukemia-free survival as well. So these results were consistent with previous studies in iron chelation therapy in MDS. So we were all waiting for a randomized study. So this randomized study was TELESTO study, the first prospective randomized placebo-controlled study, initially designed to be a phase 3 trial, but was later converted from phase 3 to phase 2 study. So the primary endpoint of this study was event-free survival. This is the Kaplan-Meier curve. And so, as you can see, for event-free survival. So there is a 1-year increase in event-free survival and a significant risk reduction in the Ferazerox arm. So you have to notice that the curve separate from the 2 years. So showing that what we expected, that is the Ferazerox take time to act, effectively act. So unfortunately, the TELESTO study did not meet our expectation because of the limited statistical power of this clinical trial. So no hematological improvement was detected and no overall survival difference between the arms. The adverse events are the ones that we already know. No new, no unexpected adverse events were observed. So this is the question for this lecture. What changed with the recent results? What changed in our clinical practice? Do recent randomized trial influence our clinical practice? This was a great paper from Norbert Gatterman. And of course, TELESTO did not change our understanding of the role of iron chelation therapy in patients with transfusion dependency. Of course, although we still have some doubts, although it is still somehow controversial, both European Leukemia Net and NCCN guidelines still suggest to consider iron chelation in low-risk MDS patients with serum ferritin above 1,000 or above 2,500, respectively. So TELESTO did not change our current practice. There is still some open questions. First question is, should we start the ferozetox with help of recommended dose? Is one question. Next question would be, should iron chelation therapy be started earlier, given the effective suppression of oxidative stress in these patients? We have many open questions, yeah. So with that, we can conclude that it is recommended to routinely monitor all patients with MDS and ongoing transfusion requirements. Iron overload is associated with measurable clinical and important clinical consequences and is associated with poor outcome. Restrictive red blood cell transfusion is recommended. And patients with transfusion dependent with a life expectancy, this is very important as well. Patients with life expectancy of 2 years or more should receive iron chelation therapy. In clinical practice, serum ferritin above 1,000 nanograms are considered a marker for starting iron chelation. It's commonly used as a trigger. Iron chelation has shown to improve survival in transfusion-dependent patients in many prospective and retrospective studies. However, the TELESTO study does not change the existing recommendation for iron chelation in patients with low-risk MDS. Decision to initiate chelations should be individualized. With that, I thank you very much for your attention.
Well, thank you very much for this excellent presentation, and we will move on now with Aplasia versus Hypoplastic MDS by Gabriela Vidal. Gabriela Vidal is a doctor in Peru. Gabriela, so the floor is yours. Thank you and good afternoon. I'm Gabriela Vidal. Thank you to the Myelodysplastic Syndrome Group Symposium and for giving me the opportunity to present this topic. As you know, medullary aplasia is a failure with pancytopenia and a hypocellular bone marrow, which is defined by less than 20-30%. This is always an exclusion criteria. There are overlaps such as HPN, congenital medullary failures, among others. It is very important to carry out the following tests for a correct diagnosis. A bone biopsy is fundamental to define the cellularity of the bone marrow. Reticulocytes are also something that helps in the diagnosis and determining the genetics for the myelodysplasia, ruling out. In case the sample is insufficient, FISH will help. Then the chromosomic fragility test to rule out Fanconi anemia, and telomere length to rule out telomeropathies. Flow cytometry is used to rule out HPN clones. However, myelodysplastic syndromes is a group of disease where there's clonal disorders characterized by cytopenias and dysplasia with a risk of transformation to AML. According to the classification of the WHO, we will have a persistent pancytopenia with a dysplasia of one of the three series, blast excess and cytogenic anomaly. In case of MDS, a good aspirate with hemosiderin dye, and sometimes we expect 500 cells with a bone biopsy, which is required for diagnosis. The genetics here are fundamental to be able to determine if there are cytogenetic alterations. FISH, in case of hypocellular bone marrows, is also good to detect chromosomic anomalies, and flow cytometry in this case especially is used for the typing of blasts and to rule out HPN clone and hypocellular bone marrow, because this is not still the method to diagnose dysplasia. There are minimum criteria for MDS, as we know, and we have to review them in order to carry out an adequate diagnosis. What are the hypoplastic myelodysplastic syndromes? They have a hypocellular bone marrow where the cellularity has been decreased in less than 25%. In case of young patients, these could be reduced for their age. This is why the cellularity less than 25% in patients less than 65 years of age is consistent to define hypocellularity. But in the elderly, the definition of hypocellularity is actually a problem. It is not a different subtype, if you will, in the last classification of WHO. To differentiate hypoplastic MDS versus medullary aplasia, it is necessary to consider some things. We know that the bone marrow, its cellularity, is normally calculated based on the age, and in case of hypoplastic MDS, you have to comply with certain criteria. And these cases of hypoplastic MDS account for 15% of all cases, and aplastic anemia, we already know the criteria, but there might be some erythrodysplasia which might be misleading and make the diagnosis harder. We know that medullary aplasia has a mechanism where the immune type destruction is characteristic in this case. These mechanisms might coexist, and this is somehow complicated to get to a diagnosis. Classically, medullary aplasia has a decrease in the progenitor cells. In hypoplastic MDS, apart from this decrease, the hematopoietic cells to clonal cells with alterations, clonal alterations, and in myelodysplastic syndromes, we will then have this characteristic of having aberrant cells. Both in hypocellular MDS and medullary aplasia, we will also have an immunological alteration. This is why they look very alike, and this shows a overlap of these different syndromes, and it might include an HBN clone, and the other pathologies are shown here as well, which might overlap and be associated to myelodysplasia. What are the general characteristics of the MDS? Generally, they are younger patients. They have severe neutropenia, thrombocytopenia. They depend on transfusions. They have lower percentage of blasts. They have lower ring cytoblasts and cytogenetic anomalies. A higher prevalence of HPN clone. They are low risk according to IPSS, and they have a better survival rate than compared with other cases. There's a lower accumulated incidence in terms of evolution to AML. The rate of mutation is less of splicing type compared to hyperplastic MDS. We have some graphs here where we have the global overall survival, the overall survival compared in myelodysplastic syndromes, hypoplastic syndromes, normocellular syndromes, or aplasias. And we see that aplasias have a better survival and a lower accumulated incidence towards AML. And the hypercellular myelodysplastic syndromes are having the worst prognosis towards AML conversion. The cytogenetic and mutation anomalies are shared in a lower, lesser degree in AAS, MDH, and SMD. We have medullary aplasia, does not have genetic lesions. Hypoplasia syndromes have more somatic mutations. There's an absence of specific genetic lesions in MDS and highly suspicious cytogenetics anomalies in normocellular MDS, and the hypoplastic are 50-50. There are mutations in medullary aplasia. Excluding PIGA mutations, up to 20% of patients harvest ASXL1 mutations, among others. There are somatic mutations that are associated to a longer duration of disease, telomeres that are shorter, and a likelihood of progressing towards AML compared to those patients without mutations. I'm sorry, she's going way too fast. This is a graph where MDS are compared to medullary aplasias. These are the PIGA gene alterations, which is something that's mostly found, and the other less frequent, less than 2%, are DEP2, which are present in greater percentage in myelodysplastic syndromes. There's a whole series of mutated genes that is important to recognize, because it will be good to know what is the impact of these mutational studies whenever we will have access to them, because they will help in the diagnosis with morphology, genetics, and it will anticipate what's the prognosis of these patients. It might refine the prognosis prediction, and it might even predict a response to treatment. So the myelodysplastic syndromes are very hard to diagnose, if you will. Distinguishing hypoplastic MDS from aplasias is quite a challenge, because patients with these diseases will share characteristics. The hypocellularity of the bone marrow makes it difficult to analyze the morphology, the dysplasia. This is also something that hinders diagnosis. Some patients with medullary aplasia have somatic mutations, and they are recurrent in patients with myelodysplasia. And there's even a group with low-risk aplasia where the inflammation will foster the response to immunosuppressive therapies that share characteristics with aplasia. Up to 15% of aplastic patients will evolve to MDS and AML. There will be dysplastic findings in both entities. Yes, there might be dysplasia, erythroid dysplasia in medullary aplasia. Myeloid dysplasia, if it exists, is mild, and of course, it's in case of a hypocellular bone marrow. But in the other case, this megakaryocytic dysplasia is marked, and there's a severe dysgranulopoiesis, which is highly specific of MDS. If we don't have a different armamentarium for diagnosis, morphologically, it is very useful to know about these differences. There's a proposal that Dr. Bennett, since 2009, proposed, conveyed, to two types of MDS. One integrates the characteristics, both histological and genetic characteristics. There's a group of patients where their clinical and genetic characteristics are highly consistent with myeloid neoplasia. And in the second group, these are patients who have clinical and genetic characteristics of non-malignant failure. We have the myelodysplastic, hypoplastic syndromes, which look like aplasia the most, with cytotoxic and pro-inflammatory cells, a decrease of regulatory cells, an increase in immune activation, and an increase in response to IST. Those who are MDS-like, it's marked by a decrease in immunosurveillance, increase of regulatory tumor permissive cells, survival of dysplastic cells, burden of genetic lesions. In practice, what characteristics will support the differential diagnosis? If it is MDS, the morphological dysplasia. Watch out the megakaryocytes. If there's absence of megakaryocytes, you have to think about aplasia. This is something that you will be able to visualize in the bone aspirate. Blast excess, of course, this is myelodysplasia. If there's ring sideroblasts, fibrosis, Pelger-Hewitt or pseudo-Pelger-Hewitt cells. This is very important information that will help us make the differentiation. It is also important to try to make the differential diagnosis with hereditary syndromes, which many failures can evolve to MDS and leukemia. Patients with GATA2, DDX41, and AF or telomerase complex genes might have a hypoplastic bone marrow even before developing a clonal myeloid disorder. It is important to identify them based on the health of the different members of their family and to see who might be a candidate to transplantation. Some mutations can cause thrombocytopenia and megakaryocytes dysplasia. There might even be present in patients without family background. So sometimes they are adult, young patients without phenotypical characteristics. Specific tests are advised if there's a suspicion. And this is the educational chart of ASH of 2019, where we can see some important characteristics to be able to differentiate the genetics, the PNH clone, the blasts, only in medullary dysplasia, and somatic mutations that are normally absent in aplasia without splicing in this case. And here we have this same chart to emphasize the difference that there's post-medular aplasia, where the cellularity of the bone marrow has been increased, and there's also increase in the percentage of blasts. There's a score, the HG score, that was published in 2019 with a characterization of this MDS to define their diagnosis compared to medullary aplasia. There are cytological and histological variables, the presence of blast, fibrosis, These are some criteria like ring cytoblasts, among others, the karyotype, and the specific mutations. If the score is 2 or plus, is associated with the highest percentage of correct classification. It tells us that it is MDS more likely. And here we have another comparative chart. I was showing this to determine the karyotype that we normally know. In MDS, it's abnormal in 50%. In medullary aplasia, it's 12% only if there exists. It's a very low percentage, and the karyotype of hypoplasia can include alterations in chromosome 5, 7, trisomy 8, and so on and so forth. If it's a medullary aplasia, this might evolve to monosomy 7, among others. In complete cytogenetic disorders, they are complex, and in somatic muted genes, there's a list of genes, P53, but in medullary aplasia, they are normally alterations of PIGA, VCOR, L1, and VCOR, and in germinal mutations, we have to evaluate them both in both groups. We have another comparative chart here regarding this type of mutations, to remember that there are some mutations that will be rare in medullary aplasia, like P53, which are tumor suppressors. We have transcription, RUNX1, CPA. They are more frequent than in hypoplastic MDS. Some words about the immunosuppressive treatment on MDS. This has been described since 2012 about the treatment for MDS in low-risk patients, hypocellularity, where they were favorable prognostic factors like ATG, cyclosporine, alemtuzumab is one of them as well. And these favorable factors were present with hypocellular bone marrows with trisomy 8, CMD non-secondary. The suppressing therapy was given, and there was a group of patients who recovered. So we saw that there's a good degree of response with these patients. And also there is a study published in 2018 with patients who received immunosuppressive therapy with some overall response up to 50%. And the variables which were associated to greater independence from transfusion has been the horse pneumocytic toxin, where there was no so much association with DR15, the clone that some mentioned. Well, basically these two criteria. So this is everything that I have to share with you. Please fill out the survey for GLAM, and I hope that you have liked my presentation. I will be here for your questions.
Very well, thank you, Gabriela. Excellent presentation. And let's continue with the clinical case by Dr. Carlos Hernández. Dr. Hernández from Mexico. So please go ahead, Carlos. Thank you very much. Well, in the next 2 minutes, I will submit a work we did, the Center Specialties, Mexico Century 21st, where I work. It's a diagnostic conclusion of patients with unexplainable cytopenias, a work we did with Dr. Andrea Martinez Gordo and Maura Fosefina Rabelo Carrasco. we start asking that cytopenias are the most frequent case of consultation with the hematologist, and having a landscape of possible diagnosis is useful for guidance to the patient and the study protocol. Here you see the different cutoff points to define cytopenias, anemia, neutropenia, and thrombocytopenia. You can see that they're very similar. Maybe the main difference is in the number of neutrophils. Usually we use the WHO 2008, 2016 classification, the same cutoff point, but now let's see how do we consider this. So we decided to do an evaluation of the patients that had persistent cytopenias, in which we wanted to evaluate the initial clinical characteristics and the final diagnosis. We considered unexplainable cytopenia to those adults that had started a study protocol in the first or second level of care. Let's mention here that in Mexico in general, in the public institutions, there are three levels of care. The first level is for the general physicians or family physicians. The second level tends to be the internal medicine physicians, and then you will go to the subspecialist, the hematologist in this case, which is the hospital in which I work, which is a third level hospital. Well, these patients had already started a first study protocol both in the first and second level of care, and they had not reached the conclusion on what was the cause for this cytopenia. And the cytopenias, we consider them based on the ICUS criteria, where you can see how the number of neutrophils is less than 1,000 per microliter. That it's usual that we do not start the neutropenia study when the patient has 1,700 neutrophils, which will be neutropenia according to the WHO criteria. These usually are lower figures, lower numbers when we start the study. We do bone marrow aspirate cytogenetic studies, flow cytometry, and we consider diagnostic conditions in two types: clonal disease, when it's myelodysplastic syndrome, aplastic anemia, or leukemias, and non-clonal disease, when it's autoimmune cytopenias, hepatopathy, and carential problems. Well, during 2018, there was a retrospective cohort with 76 patients that fulfilled these characteristics of having unexplainable cytopenias. We can see that the median age at the beginning was 61 years old. A little bit more male than female. In the initial diagnosis, we can see that 64% of them have bicytopenia or pancytopenia. In the cytopenia that we isolated more frequently was common cytopenia, and 16% lower. In the table, we can see which are the indicators as for the mean levels of hemoglobin, neutrophils, platelets, and we can see that the deeper neutropenia, considering the criteria of the National Institute of Cancers, was thrombocytopenia, which was a serious thrombocytopenia less than 40,000 in comparison with anemia, which was a moderated anemia. And we can see that in every case it was a hyporegenerative corrected reticulocyte anemia. Out of these 76 patients, I'm going to see the table from the below part to the upper part. They all had exclusion tests. We can see that the renal tests were done to everybody, and most of them we had a thyroid profile and autoimmunity tests that were done in the patients in which there was a high suspicion of some problems. Actually, we can see that even when we did it less than half of the patients, it was abnormal in most of them, in 46% of them. However, we consider these abnormalities here described that were not explaining the cytopenias that the patient had. All the patients had panels for hepatitis A, B, and C, HIV, non-reactive, and we did cytogenetic analysis by conventional banding, GTG, and we can see that most of them had a cytogenetic study which corresponded to the classification SCR, like very good and good, 78%, just a few of them, 8% had adverse cytopenia. And as flow cytometry, it's important to mention that in our center we have the Euroflow standardization conversation, and the cytometrist described a conclusion or a comment of what is the situation with regards to the different levels, linoid, erythrocytoid, and myeloid, and the progenitors of blast count. It was myeloid dysplasia. 74% of the patient, it was the main cause, and the median blast score was 72%. 2%. This is the conclusion. We just wanted to know what was the result for these patients with inexplainable cytopenias. We can see that 79% of them had clonal disease, 21% had non-clonal disease. We can see that the main pathology that was being diagnosed was myelodysplastic syndrome in 51% of the cases, plastic anemia 16%, and the other non-clonal pathologies come after that. Immunological cytopenias 13%, which corresponded to most of them immunologic thrombocytopenia or Evans syndrome, or secondary cytopenias, in this case hepatic problems, pathopathy, in biliary deficiency in one case. All the other clonal diseases were monocytic chronic, acute myeloid leukemia. There was an hereditary hemolytic anemia case as well. And something worth mentioning is that once they came to us, the mean time for diagnosis of each one of these pathologies was 1 month. But what is interesting is that when we analyzed since when they were having the cytopenias, we saw that in most cases it was 5.3 months, and even years, 3 years. We had patients 3 years that had 3 years with the cytopenia until they were referred to us in order for us to make the diagnosis. To try to identify or to try to identify which patients had clonal or non-clonal pathology, we made a comparison of which were the variables that in the baseline could suggest us that diagnostic conclusion. We can see here in this table then that the cytopenias were deeper in patients with clonal pathologies, which was statistically significant. We can see that the neutropenia was lower in clonal pathology, the same for neutropenia, clotopenia. Something that is important here is the presence of the monocytes. The monocytes were low in patients with clonal pathology, when we know that usually monocytes, unless we're thinking in mediomonocytic chronic anemia, usually we do not pay that much attention to that cell. That's why it's something that is significant here, and some other aspects that we have seen in different pathologies, like in Chile, how the elevated mean corpuscular level could signal these clonal type of pathologies, although the difference is just 8 hectoliters between the clonal and non-clonal. But I think that it's anyway interesting to see patients with tendency to macrocytosis that could lead to clonal disease. And then we can see how the presence of blasts of myeloid dysplasia were generally more present in the clonal type of pathology. The mean survival follow-up was 13 months, and we have the projection of overall survival 2 years. In the non-clonal was 100%, in clonal was 82%. We selected the patients with low risk MDS, that it's 76% of the myelodysplastic syndrome had low risk, which is something pretty repetitive in all series. The overall survival at 2 years estimated is 86%, and just as a comment, most of them had or anemia or thrombocytopenia, 72%. And let's consider that the first line, these are the main alterations. In the first line, erythropoietin or any stimulant of erythropoiesis, or danazol, based on the situation. And the second line, we usually use cyclosporine or GAT. So which are the conclusions here? Well, most of the patients with unexplainable cytopenia started with bicytopenia or pancytopenia. The deepest isolated cytopenia was thrombocytopenia. The most frequent final diagnosis was clonal disease, especially myelodysplastic syndrome and aplastic anemia. The indicators that were related to the clonal disease were deeper cytopenias, microcytosis, and dysplasia in the flow cytometry. Well, my appreciation to the team of hematologists of the hematology service of the Siglo XXI Medical Center in Mexico, residents, assistant doctors, and particularly Dr. Andrea Martinez Borgon and Master Laura Josefina Ravelo Caraz. Thank you very much for your attention. Thank you very much, Carlos. A very good presentation, the clinical case. So now we will go to the Q&A session. Well, we will start with the Q&A session. So let's select the questions. There is one question for Dr. Magalhaes. Would you chelate all the patients independently from their age? That
I do use, and thank you for repeating. I do use chelation for every patient who has ferritin level more than 100, 1,000, and 1,000 nanogram, and especially if this patient has an expectancy of life more than 2 years.
Okay. Thank you.
Carlos, can you continue, please? Yes, good afternoon. I have one question for Dr. Gabriela. It's with regards to in the 3 series that you evaluate in the patients with hypoplastic myelodysplastic syndrome versus in order to rule out medullary hypoplasia, which of the series do you give more importance? Because in medullary aplasia, there are also some hemopoiesis, but which of the series you could take more into consideration from the cytomorphological point of view when you do a diagnostic in the hypoplastic MDS? Thank you, Carlos. Well, I always mention to my students and in general that they have to need to look at the megakaryocytes mainly, because if I see a bone marrow without megakaryocytes or almost without megakaryocytes, I'm thinking more about a medullary aplasia. Obviously, the biopsy will help us extensively to identify this, because sometimes you might not see them in an aspirate. And then you also have the staining, C31, 61, to identify the megakaryocytes. So that, I believe, it's critical, because if I describe erythroid dysplasia, well, in both I could see myeloid dysplasia, also a little mild maybe in the medullary aplasia, even though it is not that frequent. But in the case of the megakaryocytes dysplasia, the presence and sometimes abundance makes me suspect of a hypoplastic MDS. Thank you, Gabriela. And it's very clear, the concept of the megakaryocytes, which give us a guideline in terms of the differential. There is a question, actually. There is a question from the chat. They mention a 28-year-old male with 10 of hemoglobin, celularity 50%. They do not describe dysplasia in the bone marrow, and it has an erythropoietin of 13. How would you treat, well, this person? Well, in reality, we have to always consider the age of the patient in order to be able to determine whether an bone marrow is hypocellular or not. And this, as I said, we do a simple rule of decreasing the age at 100%. If he's 28, then 50%, the cellularity might have been decreased, yes, but however, it is not a parameter for treatment. If it depends on the cytopenias this patient has. Here, the only data is that he has 10 hemoglobin. So the only area affected apparently is the erythroid series. This is an hypocellular bone marrow without dysplasia. They do not mention anything about the genetic, if there's any genetic alteration, which is important to determine as well. And he has an erythropoietin under 500, which we might give erythropoietin. Yes, I believe that in this case we could try that. But obviously here, well, we need more data to clarify whether this is myelodysplastic syndrome or not. That's the question that I read, that was made to me. I believe that there is a question for Dr. Pierre Fenaux. I think he's back. Is he back? Yes. Dr. Pierre, it's a pleasure to greet you here. Well, something that we want to know is that the myelodysplastic syndrome 5q minus the response to lenalidomide, whether we want to know whether there are any trials that are being done with some others, older brothers or sisters than lenalidomide, in order to evaluate the possibility of a greater efficacy, or there are not, like maybe podolidomide. Can you hear me? Yes, we can hear you. Well, I believe the ponamilamide doesn't work. It doesn't work in patients with deletion 5q. I don't think that there is much experience about that, but the thing is that lenalidomide, it's pretty efficient if you use 10 milligrams a day, particularly, and I believe that, well, I don't believe that it is. No, I believe that there are patients that are resistant. Yes, those that have a mutation TP53, which who do not respond to this drug. That's true. Yes. Hi. You have also mentioned that the use of lenalidomide, there are also patients that have a response despite the fact of not having the deletion of 5q minus. What would be why is this, do they have this response? What do you think? Sorry, I couldn't hear you well. Patients without deletion 5q, if you can use the drug, that's your question? Yes, I understand. I was saying that there are some degree of response in patients with that do not have the deletion 5q minus, but they have a response nevertheless. That is, there is a response, those that are refractory to the previous treatment. So what would you think, why do you think this response happens, or why don't we start treatment in them despite not finding the deletion? Yeah, the response rate with in patients without deletion 5q, well, the response rate is only 25%, which is not that much. But yes, if you add erythropoietin, it seems that it will go to 50% in patients that will resist, obviously, the EPO. But if they do not resist EPO, well, it's better to start with EPO. And I believe the mechanism of action is different in patients with or without the 5q deletion. We do not know what is the action mechanism in patients without the deletion. There is another question here for Dr. Fenaux. What is the management of a patient with refractory anemia and trisomy 8 that doesn't respond to erythropoietin? Pass or back? Well, I don't think that there is no much difference. I mean, trisomy 8 is a worse prognosis factor. I mean, if it is a patient that it's pretty young, it might be this patient might be a candidate to transplant because we know that these patients, unless there is, I don't know, only 3 mitosis, let's say, with trisomy 8 in 20, but most of them will be patients that will evolve, that will have a progression. So it would be, if there's no EPO response to EPO and there is a progression after disease, it's not a good prognosis, not a good prognosis. You might try to use azacitidine, for example, but if the patients are very young, well, you know, probably at certain point, this will be an indication for transplantation. There's another question for Dr. Fenaux here related to that. Actually, it says, what is the dose, the initial dose of erythropoietin, EPO, if it depends on the severity of the anemia and if it is if it is useful to use GCSF to improve the response. The use of GSCF, I believe, improved the response with a very low dose, like 30,000 units per week, maybe. When you use 60,000 units, GCSF doesn't add too much, to EPO. So what we usually do is that especially in all their patients, elderly patients, we try to, well, try to have to see what happens if the patient has been has had a transfusion. We start with 60,000 units a week or 300 micrograms of RNFs. Now, the patients that have less important anemia or elderly people that many times have kidney insufficiency, in that case, we need to start with lower doses, 30,000 units maybe every week or 30,000 units every 15 days. Because no, there is, what you need to do is a rapid increase of the hemoglobin rate, and there could be thrombosis. So we discontinue the treatment when we have 12, 13 hemoglobin, but not more than that. And there might also be a rapid increase with a risk of thrombosis. So I believe that it is important that there is a CBC every week during the first 2 months. Perfect. Thank you. Thank you very much. Yes, Victor, go ahead, please. Well, another question on the erythropoietin EPO that the people is asking if there is a place for the combination of EPO and lenalidomide in patients with deletion 5q, or you need to suspend EPO once you start with lenalidomide. I believe that we do not have a very important experience with that. Usually we start with EPO, and if it does not work or if there is a relapse, then we will go to lenalidomide alone. The risk with the combination in reality is that there could be, again, a too rapid increase in the hemoglobin and a risk of thrombosis, which also exists with lenalidomide alone. And so, well, I don't think there is I don't think there is a publication really with using this combination in patients with 5q deletion and determining whether it is better than lenalidomide alone. Okay, thank you very much. There is a question for Dr. Fenaux. What is the role on the use of the androgenic derivatives, oxycodone and azole? I believe that I think that it's more on, they have more an effect on thrombopenia. We have published a series of patients that with a response rate of around 40%, especially in women. Um, and well, generally a not that a long duration, but there are patients that have an improvement, and that doesn't depend on the thrombopenia mechanism, because we know that there might also be a peripheral component in MDS, but patients with any mechanism, whether peripheral or central or both, I believe that that's not allowed us to foresee the result of the androgenic drugs. That might be interesting. Yeah, sometimes there are results on anemia, but it's mainly on thrombopenia. Well, there's another question. There are 3 episodes.
There is a patient with 3 episodes with severe cytopenias associated to Epstein-Barr and parvovirus. At that time, there was a bone marrow biopsy and a cytometry that was compatible with MDS. They responded to cyclosporins in the intervals of 1-2 years. They don't have cytopenias. Could you comment on this, please? Well, this is not a, yes, it's an MDS case associated to an infection by cytomegalovirus and parvovirus. They treated this with cyclosporins, and after 1-2 years, the patient is recovered. Could you comment on this, please? What are the arguments to decide whether this is MDS or not? Because there might be dysplasia in cases of infections with viruses. And if there's no cytogenetic anomaly or molecular anomaly, it's difficult to say that this is MDS. And apart from this, the full correction with cyclosporins makes me think that maybe it was an aplasia after a virus. I don't know. If there are definite arguments for MDS, but I don't think there are. Yes, we need more data to give a question here. There's another question for Dr. Fenaux. They are asking about the maximum dosing of EPO, the maximum dose of EPO that can be used in refractory anemia with no improvement when there's no other therapies available. Well, I think that the maximum dose is 80,000 units per week. And for EPO beta, I don't know if this has been tried, and it's 300 micrograms per week. Sometimes they use 500 micrograms. I don't know if this is vast. And of course, GSSF might be added, though it might not increase the response rate importantly when the dose of erythropoietin is still important. Maybe it could go from 10% to 15%. They ask if you have experience in using EPO, endovenous, IV. They say that in some countries there's low concentration and it's hard to administer high doses through this route. I think that it might be used IV. I don't know. I know that initially this is how they used it. I think so, yes. Well, thank you very much. Okay, then for Dr. Hernández, Dr. Carolina Belli is asking, the Mexican registry data showed a higher proportion of hypoplastic. Do you still see this kind of findings? Well, it's true. The hypoplastic that we saw in our registry, it was around 50%. Actually, particularly at my center, the frequency of hypoplastic MDS is around 7-8% now. So it's a little bit lower, but it's different. In some Latin American countries, it's more than it's reported. It seems that very likely we are over-diagnosing hypoplastic MDS, and maybe it's aplastic anemia. We know, for what Dr. Gabriela mentioned, that sometimes it's hard to perform the differential diagnosis, and we know that the main tool that we have available to obtain some certainty is the cytogenetic study, and genetic studies in general are not typical here. So in conclusion, yes, we do have more cases, around 7-8% at our hospitals, but it's worth integrating myelodysplastic, hypoplastic cases at our center and see what are their characteristics. And it would be ideal to take a look at the genetic study, not only the cytogenetic study, because maybe we are overdiagnosing hypoplastic MDS. Dr. Elvira Veloso is asking something regarding the clinical practice in your practice, are you using mutations for distinguishing aplastic anemia and MDS H? Can we study these mutations in peripheral blood? Yes, the question of Dr. Veloso, we, in our clinical practice in Peru, we don't have access to performing this mutation panel that we should do, at least in pediatric patients. In patients below 20 years of age, there's only one center here in Peru which is implementing this panel for mutations. We are not doing this routinely. The only thing that we have is cytogenetics and the pathology. We don't have FISH either. This is our reality, unfortunately. And sure, the idea is to implement this soon. And the samples, I understand, might be from the bone marrow, but we don't have this at our disposal. We've worked on exceptional cases where the samples have been sent abroad or have been carried out in the pediatric hospital that I mentioned, but many of those patients could have a hereditary failure, who knows? But we don't know. Okay, thank you very much, doctor. To all of you, there's a question by Dr. Belli. There are two questions, actually. The EPO dosing that you use, the starting dose, and if you all have access to lenalidomide with non-5Q patients in Latin America. Dr. Vidal, would you like to take over? EPO dosing, and if you all have access to lenalidomide in 5Q. As I told you a while ago, the EPO dose that we have, at least at the general hospitals, it's 4,000. So to get to 30,000 dosing, which is the top dosing that we use, we very rarely reach 60,000. In pediatrics, it's 10,000, and it is expensive, by the way. In some patients, we had these 60,000 doses with 10,000 ampoules or bottles, but we are using this, and we have used in patients who are not 5Q negative. We don't have fish, and in case of refractory anemia, even morphologically, these megas, which are typical, have made us ask for this, and we've had an authorization, and we've had lenalidomide successes. In Mexico, there's something similar going on. The alpha EPO, the conventional EPO, is 2,000 to 4,000 at the ampoule. So we used to standardize at 110, 120, 3 times a week, meaning 8,000 units Monday, Wednesday, Friday. This is still the starting dose. The maximum dose is 80,000 units per week, but in general, as it means that there's a lot of ampoules used, what we do normally is the dose of 24,000 units does not work. It was not effective. We switched to darbepoetin with 500 micrograms every 3 weeks, which would be equal to 50,000 units per week. And the maximum dose that we use is darbepoetin, 500 micrograms every 2 weeks, equal to 80,000 units per week of the other erythropoietin. Lenalidomide at the institutional level, it's there's no lenalidomide available for MDS, just as second-line therapy for myeloma. But institutionally, it's only for 5Q minus.
In Brazil, we have the 10,000 presentation of EPO, and we can use 60,000 units per week. We observe the patients for 3 months to check for a response. And the problem is really when the patient is refractory or lose response. And so this is the problem of second-line therapy. In general, for us, it's most feasible to use ASA instead of associate lenalidomide because it's not approved for the public system of health in Brazil. Yeah.
Any other comment? Yeah, I wanted to mention about the reality in Uruguay for erythropoietin. We also have vials of 4,000, 6,000, and 20,000. We start with low doses, and then we go to increase the dose based on what happens with every patient. But as in other countries, it really depends on what sector of the health sector we're talking about. I mean, if we're talking about the social insurance sector, you will have access to 10,000 and 20,000 vials. However, in other sectors you won't. With regards to lenalidomide, yes, if we justify well the situation of the patients, we have access to the use of lenalidomide in myelodysplasia with 5-key deletion. Is there any other comment? There is a question for Dr. Magalhaes.
Test in most services. We use most frequently serum ferritin. So it's cost effective, it's simple, it's we can access it. So it's important to consider that it's acute reactant. So we have not only check one single dosage, but a sequence of those to check. So that's what we use most frequently in our practice. In fact, there is quite a few studies of RMI in MDS. Maybe it would be interesting to listen to Gabriela and Carlos' experience in other countries of Latin America.
Well, we use the levels of serum ferritin. We evaluated transaminases as well. Sometimes we do MRI to check at the accumulation of iron, but we do not have it available. I mean, we do not do it routinarily. In some special cases, we do it when, for example, patients that have a liver compromised transplantation, but it's not something routine that we do. We do not do it routinarily. In Mexico, when we have patients with iron overload, the IMR, the truth is that we do not have it available. In my center, yes, we have MRI that is reported qualitatively, and it's curious because it's only based on how black the spleen or the liver is. If it's very black, it is, and if it's gray, it is not. So it's pretty trivial the way in which we determine these things, but usually in our patients, they have so much transfusional accumulation that it's clear that you will notice this accumulation. It is very simple, even because there is even a software, well, there's a website actually where you can feed in the data of the standard P2 modality. You just introduce the data that they ask you for, and I discussed this with the radiologist once, and he told me, yes, you just put in the data and they will give you the equivalent in grams of iron that these measurements are. So sometimes you get too complicated and it's not. So in our center, we just have qualitative magnetic resonance and what we consider, especially what we consider to define the beginning of the chelating therapy is a transfusional history that it's more than 20 units, and ferritin and the transferrin saturation, knowing that ferritin will increase with the implant and all of that. And something else as an addition, we did an analysis of our patients that had 10 units of erythrocytary concentrate, and at what time did they reach 20 units, at what point, how long would it take to get to the overload point, and the time it took, it was around 7 months. It's not that much time once the patient has accumulated 10 units of transfusions in a medium of 7 months, they will be ready to start chelation. Excuse me, I wanted to ask a question to Professor Fenaux, taking advantage of the time. If luspatercept, do you think that it could be given to patients that do not have GSF3B1? Yes, what we know is that the efficacy is lower in patients without sideroblast, ring sideroblasts, or DSF3B1 mutation, but yes, there are some patients that have a response, yes.
Hi, Pierre. My question and my doubt is, as we know that both agents act in different stages of erythropoiesis, do you think it would be a good idea to combine EPO and luspatercept? I know you don't have studies yet.
Yes, of course, and this is our next study. I mean, to compare in patients who are resistant to EPO, luspatercept alone or luspatercept plus EPO. This is going to be a GFM study in combination with the Italian colleagues.
Yeah, I see your presentation. It's great.
Muy bien.
Very well then. Do we have any further comment that you might want to make? I mean, the speakers. Anything else? Any other comment? Very well then, we would like to thank you all. All of these have been excellent presentations. Thank you, Silvia, Professor Fenaux, Gabriela, Carlos. Thank you very much. Thank you, and see you tomorrow. Bye-bye. Thank you.